Thank you everyone for joining for the third lecture that Dr. Nicolaou is giving here in our CyberPatient Expert Series. The CyberPatient Expert Series is an ongoing collection of webinars consisting of talks given by various medical professionals. And the goal of the series is for medical students, as well as faculty, to directly engage with physicians, to build connections and support the future of medicine for future medical professionals. To introduce Dr. Savvas, so this is his third lecture. So if you've seen his two previous lectures, you would have gotten this introduction. He's the Director of Emergency and Trauma Imaging at Vancouver General Hospital and a Professor of Radiology at the University of British Columbia. He's completed his medical degree at the University of Toronto and residency in diagnostic radiology here at UBC. So Dr. Nicolaou has consistently worked to improve equitable care for patients, has successfully worked to improve education throughout his career, and continues to be a major contributor in the field of emergency radiology. Under his leadership, the radiology subspecialty care at VGH is now being presided to underserved and Indigenous communities within the Interior Health Authority, as well as caring for adult female patients at BC's Women's Hospital. He's also actively involved in teaching medical students, residents, and fellows, and served as the UBC Vice Chair of Undergraduate Education and Continuing Professional Development for more than 11 years, and has received multiple awards for excellence in education. And he's also published over 180 articles and over 400 abstracts in peer-reviewed journals with a particular interest in ER trauma, musculoskeletal, and cardiac imaging. So last lecture, Dr. Nicolaou covered chest X-ray and approach to imaging acute chest pain, and before that covered an approach to the interpretation of the abdominal radiograph and the acute abdomen. And today, for the third lecture of the series, he'll be speaking on an approach to brain imaging. So thank you, Dr. Nicolaou.
Thank you, James. Thanks for that great introduction. Thank you, everybody, for joining us today and taking the time out of your busy schedules to be with us today. So today's talk is going to be an introduction to brain imaging. The objectives will review some normal brain anatomy on computer tomography. A basic approach to reading a CT scan of the brain will be the major emphasis of the lecture. And then we'll go to some review of must-see acute brain cases with imaging management decision-making. Two types of CT heads that we look at in the acute environment: a non-contrast examination, which is the workhorse for brain imaging. Of course, a contrast examination as well, where intravenous contrast material is administered to better evaluate vascular structures, particularly for dissections, stroke imaging, for tumors, sites of infection. And usually a relative contraindication is allergy, but now we treat pre-medicated patients with prednisone and Benadryl, and renal failure usually is the main contraindication, usually GFR less than 25. Contrast media that we've talked about before in the past are substances that are introduced into the body to help visualize the structures being examined, and they improve the ease of interpretation and also characterize pathology. These substances are primarily composed of iodine, which is a very unique element that has a high atomic weight number, and uniquely there is an exponential increase in attenuation of the structures that iodine is associated with that basically light up when exposed to ionizing radiation. On your left, you see a non-contrast CT head where we have a mass that is situated posteriorly along the corpus callosum, and with contrast material, given there's a breakdown of the blood-brain barrier, there is a unique, intense enhancement of this mass that is barely delineated, the size and extent of the mass. It also gives us some insight as to the type of pathology that is existing within the brain parenchyma. Now, common indications for head CT is trauma, of course, acute stroke imaging, suspected subarachnoid or intracranial hemorrhage, extracranial hemorrhage as well, such as epidural and subdural hematomas, evaluation of headache, worrisome type of headaches, particularly that are worse in the morning, evaluation of sensory and motor function loss, and evaluation of sinus cavities as well, particularly preoperative for sinonasal surgery. Before we begin, there are some key concepts that we must talk about that you should be expected to be familiar with. One is what we call a Hounsfield unit, windowing and leveling, and also the different types of planes we utilize with imaging with regards to the brain. Now, what is a Hounsfield unit? This was named after the inventor of CT. CT scanners record the attenuation, i.e. the brightness of each pixel in Hounsfield units of a particular compound. This number represents the relative density of the scanned substance. And this relative density is primarily based on two components: the atomic weight composition and also the electron mass density of a substance. Both can give rise to an increased attenuation of a compound within the brain, one being calcium. Calcium is a high atomic weight number and can be seen as a bright structure within the brain. Also, that is due to the high atomic weight number of calcium. Of course, hemorrhage does not have a high atomic weight number, but has a high electron mass density that also increases in attenuation when exposed to ionizing radiation in the brain. This ranges usually between -1,000 and +1,000 Hounsfield units that we'll do a deep dive into over the next few slides. Now, different substances have different relative densities and thus different Hounsfield units. This is very useful in the brain, of course. We can see that air has -1,000 Hounsfield units, bone +1,000 Hounsfield units, but compounds such as blood, +40 to 80 is very useful and helps us to characterize if we're seeing an acute hemorrhage. So image display windowing, the CT value of water is 0 and air is -1,000, bone being +1,000. Those are values of other tissues are calculated relative to the attenuation of water, as this graph illustrates, where we have compounds such as calcium or metallic compounds that can be as high as 3,000 Hounsfield units, water being 0. And then we have compounds such as fat, which can be useful. There are certain tumors within the brain that are fat attenuation that are very useful for us to be able to characterize. They're in the range of -100 Hounsfield units. And then we have air, which is -100, can be very useful as well for compound fractures that it can introduce air within the either intracranial or extracranial, known as pneumocephalus. The range of density of values is defined from -1024 to +3071, but the human eye can only distinguish 30 to 40 grayscales at best. So the window settings must be in accordance with the structures to visualize. In this particular example, as James discussed in our last talk, was air, if we want to visualize the lung parenchyma. Of course, soft tissue, if we want to visualize the vascular structures within the mediastinum. Now, the rule of thumb is you set the level at a point which is roughly the same value as the average Hounsfield unit number of the tissue of interest. So the window width is the density range represented within the gray scale. The window center is the center of the density range. And usually in the brain, we have two windows and levels that we utilize, which I will show primarily. We have a bone window, and we have a contrast window as well. And usually the bone window is set at -1,000, where the brain parenchymal window is set usually around 80, is what I would say. Now, question, if the window width is set at 300, then a range of 300 different Hounsfield units will be seen on the image. Which 300 included? Of course, that depends on the level set. If the level is set to 0, then the range displayed would be from -150 to +150. Now, we can measure the Hounsfield units using a region of interest tool. Now, any PACS system, picture archiving communication system, allows you to utilize a region of interest. And then this allows a simple measurement of the Hounslow unit, which gives us an insight into the composition of the type of material we are interrogating. For example, bone that surrounds the brain parenchyma, which is the skull, is positive 1000. CSF, which is the primary component of the ventricles, of course, would have a value in the negative range, is what I would say. And of course, if we had fat, then that would be even more in the negative range, negative 100. So that if we want to identify certain compounds within the brain, such as hemorrhage, which I'll show numerous examples of, that can range anywhere between usually around 60 Hounslow units. That can also be up to 80 Hounslow units, is what I would say. Now, in the brain imaging, there are three windows that are commonly used. Brain window being the primary window, we have a bone window, and then we have a subdural window, which is a very wide window and level that we utilize to see the blood accumulating in the extracranial space. The three different types of plane that are commonly used in brain imaging is the axial plane, coronal plane, and sagittal plane. Now let's review some of the normal head CT atlas. Now, we're going to start from the base of the brain and move to the top of the cerebrum. Now, for reference, we're scanning a patient lying on the CT table. We're looking from the feet towards the top of the patient. Anterior is where the nasal bridge would be, and the orbits of the patient and the nasal cavities. And then posteriorly would be where we would start off with the cerebellum, the right and left cerebellums. This is the right aspect of the patient, the left aspect of the patient. We have the right and left cerebellar hemispheres, the medulla situated, which is part of the brainstem. We'll move slightly superior. We come onto some important structures. These are the orbits, the right and left orbit. We have the infragyrus rectus, where the olfactory nerves course, and those being the most commonly injured nerves in trauma. And the infragyrus rectus, which is the infra aspect of the frontal lobe, is a very common site to see hemorrhage in trauma imaging, and also the temporal lobes, given their close association with the basal skull. Now, further anteriorly, we have the temporal lobes, where we have part of the temporal horns that we see here, the right and left temporal horn. Then we have the uncus, which is the most medial structure of the hippocampal formation complex, which is part of the temporal lobes. And then we have these low density structures are the CSF cisternal spaces that we'll talk about more. And then, of course, these bright structures are the actual vessels that course through the subarachnoid space. Note the midline position of the brainstem and cerebellum. And then as we move slightly more superior, again, we see the right and left orbit, the superior rectus muscles. We see the superior ophthalmic veins bilaterally. Again, we see the internal carotid arteries, the basilar tip. And here we see the midbrain, and this is the ambient cisterns and the cerebral aqueduct that we see. Again, the left and right temporal horn, the temporal lobes, cerebellum, and now we're coming posteriorly into the occipital lobes as well. Some very important anatomy that is important in stroke imaging is the delineation of this important anatomy that I will be going over in the next couple of slides. So what we're seeing right here, we're seeing the anterior limb of the internal capsule, genu of the internal capsule, posterior limb of the internal capsule, and then we're seeing part of the basal ganglia, caudate, lentiform nucleus, the thalami that surround the third ventricle, the atrium of the lateral ventricular system, the frontal horns, the sylvian fissure, and also the external capsule. That is very important anatomic delineation. That anatomy always needs to be delineated. If it is not, due to the presence of cytotoxic edema as an acute stroke imaging, that implies the presence of an acute stroke. More important anatomy, as I mentioned, the basal ganglia, the caudate, the cis adjacent to frontal horn, the lentiform nucleus composed of the putamen and the globus pallidus. And this is very important, anatomical depictions, the lentiform being more lateral, the globus pallidus being more medial, and I explain why that is extremely important. And then, of course, we have the external capsule, the extreme capsule, and then the sylvian fissure. Also, what is important to maintain when we're looking at the brain anatomy is the lateral ventricle, which is the anterior horns. Third ventricle, the midline, as we can see, when we draw a line from the anterior aspect of the interhemispheric fissure to the posterior aspect of the interhemispheric fissure, where we see the suprasagittal sinus, that should be a straight line drawn from anterior to posterior, and we should see symmetrical placement of the ventricular system to the right and the left. If not, that implies mass effect displacement either to the right or the left of the midline. Note the midline position symmetry of the ventricular system is extremely important to ascertain the presence of either atrophy or the presence of mass effect. More superior, we see the gray matter, which is of slightly higher attenuation, the white matter that surrounds the ventricular system, the body of the cardiac nucleus, and of course the body of the lateral ventricular system. And then one thing that I want to mention is the cerebral vascular territory. In yellow outlines the anterior cerebral artery distribution, which is along the midline, along the midline of the interhemispheric fissure. Of course, the primary supply of the brain is from the middle cerebral artery, which composes primarily of the anterior lobe of the brain parenchyma, temporal lobe, and also part of the parietal lobe as well. And the posterior cerebral artery, the primary component supplying blood to the brainstem, and also the medial aspects, the temporal lobes, and also the occipital lobes as well. When we give contrast materials such as iodine, this lights up the vascular structures, which is extremely important from a stroke imaging perspective, because nowadays, of course, if you have a thrombus or a clot within the proximal aspects of your circulation in the middle cerebral artery, those patients time is brain. And now, of course, intravascular treatments such as the removal of such clot is extremely important to help save the brain and decrease mobility and mortality as it pertains to stroke imaging. Some unique advancements that highly depend on the anatomical delineation, understanding of anatomy, and also quick imaging with CT to save the brain. And what we can see from an anatomical depiction, of course, here, posteriorly, we have the posterior cerebral arteries, the basilar tip, posterior communicating arteries with the posterior circulation, and the internal carotid arteries, of course. And then we have the anterior cerebral arteries, A1 segments, the anterior communicating arteries, the A2 segments that run along the interhemispheric fissures, the callosal marginal branches. That completes the circle of Willis with the M1, M2 segments of the middle cerebral artery that branch off the internal carotid artery itself. More posterior circulation that we talked about, we have the right and left vertebral arteries, which are extremely important. We have the posterior infracerebellar arteries. We have the perforator arteries, the supracerebellar artery being the penultimate branch of the basilar artery. And then, of course, we have the basilar tip and the posterior cerebral arteries. Some other angiographic anatomy that we commonly delineate with CT angiography. We can see it right here, the completion of the circle of Willis. Extremely important to identify whether you have a complete or incomplete circle of Willis, because that would help you define the significance of a clot in either one of the systems, the right or the left aspect of the brain. Posterior cerebral arteries, posterior communicating arteries, the middle cerebral arteries, the anterior cerebral arteries, anterior communicating, and the callosal marginal branches of the anterior cerebral artery itself. The supraclinical portions of the ICAs are very important anatomical structures to identify as well. The basilar tip, another important structure, and these are also common sites of aneurysms that we'll talk about later in the talk. This is a coronal plane that is also extremely important for us to look at the depiction of aneurysms. We see the internal carotid arteries that run through the cavernous sinus, the anterior cerebral arteries, the middle cerebral arteries, and the lenticulostriatal branches, which are the terminal branches of the middle cerebral and anterior cerebral arteries as well. On the coronal plane, it's a very excellent plane to depict the right and left cerebral arteries, posterior cerebral arteries, and also the basilar artery itself. And the basilar tip, another important anatomical delineation, a common site for aneurysms. On the sagittal plane, What we also need to identify is some of the venous anatomy, which is very important nowadays with the administration of vaccines and the VIT syndrome, the syndrome that is induced by vaccines that causes thrombosis of some of the cerebral veins of the brain. And we'll look at some examples later in the talk. What we see right here is the internal cerebral veins, important venous anatomy, the infrasagittal sinus, the straight sinus, the vein of Galen, and the suprasagittal sinus here as well. Now, when we look at a CT brain, what we need to identify is a basic approach. And that's what I've done with the chest X-ray and the abdomen that we've had these lectures. Now, we start with the easy stuff: patient name, medical record, the medical identification number. The age of the patient can be critically important, as the type of tumor you might be dealing with in the brain, and also the type of pathology you might be dealing as well is very important. And also the date of the examination, and also the gender of the patient as well can be helpful with certain pathologies. Always check for previous scans for comparison purposes. Findings can be very subtle. A good way to spot them is to look for changes between the current and previous scans. Even old chest and abdominal films can give you a clue to possible brain pathology, such as brain mets from lung cancer or tuberculosis of the brain if you've had previous exposure to TB that would be present usually on a chest radiograph. Now, make note of the study technique: anatomic region of the scan, head, neck, and spine, slice thickness, window level and width, the planes transaxial, coronal, sagittal, utilization of contrast, looking at the circle of Willis if it is complete, and this will be enhanced, of course, in studies utilizing contrast material. Now that you have noted all the basic information about the scan, it's time to look at the scan itself. Using a systematic approach is what I recommend, because in having confidence and utilizing this approach over time and using the same approach will ensure that you don't miss any must-see critical findings. We'll start from the inside and move towards the outside. We will start with the midline structures, the symmetry of the midline structures, the ventricles, the cisterns, the brain parenchyma, the sulci, the sinuses, the skeletal elements, and the skin and soft tissues. Now, what we're seeing right here are the midline structures initially. So you always evaluate for midline shift. Find a slice where the two lateral ventricles are most prominent, is what I would say. Usually it is a slice where you see the body of the lateral ventricular system. Draw a vertical line down the middle, joining the falx cerebri anteriorly to posteriorly. And there you should see equal sort of size of the bodies of the lateral ventricular system. Now, the reason why we do that is for midline shift. In this particular example, we can see that along the midline, we can see that it is intersecting the body of the right lateral ventricular system. And that implies that this particular mass, which is an enhancing lesion, it has peripheral enhancement, which is an abscess. In this particular example, is resulting in midline shift towards the left of the midline. This particular example, we have a tumor in the left temporoparietal region of the brain parenchyma, and that's causing a midline shift towards the right of the midline. It's important to identify midline shift because that can be a cause of subfalcine and transtentorial herniation. Identifying the ventricles, let's click on the ventricular system. We have the third ventricle that is surrounded by the thalamus. We have the cerebral aqueduct that communicates between the third ventricle and the fourth ventricle. And of course, we have the fourth ventricular system. Now, the reason why it's important to note the anatomy of the ventricular system is to identify types of pathology. We see this bright structure that is present at the level of the foramen Monro, and the foramen Monro are the two outlets of CSF that drain from the frontal horns to the third ventricle. And of course, the third ventricle drains to the fourth ventricle through the cerebral aqueduct. And then we have the foramen of Magendie, which is midline, and the foramen of Luschka, which are lateral apertures that drain the CSF from the fourth ventricle to the cisterna magna. Now, in this particular example, we see a bright structure anteriorly and this is the right and left frontal horn at the level of foramen Monroe. And this would be a classic, pathognomonic pathology, which is known as a colloid cyst at the foramen Monroe, that can result in positional headaches, positional vertigo as well, and can also result in a blockage of the CSF and result in hydrocephalus, primarily of the frontal horns, and these might have to be drained or removed through surgical techniques. Posteriorly, this other bright structure is just calcification. That's the pineal gland, which is a normal anatomical located structure. Evaluate for any changes in symmetry of ventricles, the size of the ventricles, the shape, and the density of the ventricles is very important. The density, of course, if it's bright substances within the ventricles, that implies that you're dealing with hemorrhage, ventricular hemorrhage, which we'll show some examples. A displaced ventricle is often the product of mass effect or atrophy. Both can cause displacement of a ventricle. The difference, of course, a mass will cause effacement or narrowing of a ventricle, where you have atrophy will cause enlargement of the ventricle because it's less brain parenchyma, the ventricular system expands. Now, common pathologies, mass effect that we talked about, an abscess resulting in midline shift to the left of the midline, and also effacement along the body, the posterior aspect of the body of the lateral ventricle. Atrophy, in this particular example, we can see enlargement of the bodies of the lateral ventricular system, but we know this is ex vacuo effect because we can see the cerebral sulci are also enlarged as well. The other cisternal CSF spaces would also be enlarged. Hydrocephalus, enlargement of the ventricles. We have edema within the brain. We can see this low density stuff, collections in the extracranial space. And we also have periventricular low attenuating change that implies transependymal flow of CSS, implying hydrocephalus. Intraventricular hemorrhage, as I said, bright substance within the ventricular system. Be very concerned. You're dealing with an acute pathology, and that, of course, the most common cause of intraventricular hemorrhage is trauma. We have to identify the cisternal spaces, the next important structure to look in the brain, because these are important for the identification of mass effect, but also subarachnoid hemorrhage, which is one of those must-see findings on a CT scan of the brain. So let's start with the supracisternal spaces, where you commonly identify the carotids on the right and the left. The ambient cisterns are very important structures that are located posteriorly that surround the midbrain. The prepontine cistern and the cerebral angle cisterns are very important structures, again, for subarachnoid hemorrhage. Common locations to see them from a ruptured baryaneurysm. So we have the prepontine cistern where the basilar tip sits, and then we have the cerebropontine angle cisterns on each side of the pons, and this is, of course, the fourth ventricle. The cisternum magnus sits posteriorly between the right and left cerebral hemispheres. Now, evaluate for any changes in the symmetry, size, and density again. Cisterns often contain blood with subarachnoid hemorrhage. Cisterns can also fill with pus in the setting of meningitis. And particularly tuberculous meningitis usually involves the cisterns. Now, first identify the major lobes. Now, the next important structure, let's look at the lobes, the frontal lobes, temporal lobes, parietal and occipital lobes. Frontal lobes, they're located anteriorly, and they have, this is the anterior aspect of the frontal lobes, the mid portion and a posterior aspect of the frontal lobes that is defined by the central sulcus of Rolando. We have the temporal lobes on each side of the right and left, and usually a common, easy anatomical identification of the temporal lobes is look for the temporal horns on the right and left. Another important anatomical structure that we'll talk about that identifies the temporal horns is this CSF structure at the tip of the apex, the apex of the petrous portion of the temple bone. And you can see this low density structure, I'll show you more examples, is known as Meckel's cave. It's an indentation of the dura at the apex of the petrous portion of the temple bone, and that fills with CSF, and that is known as Meckel's cave, and that's where the Gasserian ganglion or the ganglion of the fifth trigeminal nerve sits. We have the parietal lobe, which sits posterior to the central sulcus of Rolando. And then we have the occipital lobe that situates posterior to the occipital horns of the lateral ventricular system. The brain stem is an important anatomical structure to identify. The midbrain, which is surrounded by the ambient cisterns. We have the right and left temporal horns. We have the pons, of course, where we have the basilar tip, the prepontine cisterns, and then the cerebral angle cisterns as well. We have the fourth ventricle that sits posterior to the pons. We have the medulla further inferiorly, and with the sternum magna that sits posterior and the fourth ventricle to the medulla. And of course, we have the cerebellum, right and left cerebellar hemispheres as well. Now, Meckel's cave, as I mentioned, is an important anatomical structure to identify. Of course, that's where the Gasserian ganglion sits. And of course, the trigeminal nerve has three divisions: the ophthalmic division that courses through the supraophthalmic fissure, the maxillary division, which courses through the foramen rotundum, and of course, the mandibular component that courses through the foraminal valley. Now, on CT, where we locate the structure, is at the apex of the petrous portion of the temporal bone, and we can see it's an indentation of the dura that fills the CSF. It's along the inframedial aspect of the temporal bones. And of course, this is an MRI image, an axial MRI image on the right side with excellent depiction of anatomy, the fourth ventricle, the right and left cerebral hemispheres, of course, the pons, where the fifth trigeminal nerve originates, the right and left trigeminal nerves, the course where the ganglion is situated more anteriorly along the inframedial aspect of the temporal lobes and along the apex of the petrous portion of the temporal lobe that is known as Meckel's cave. Important anatomical delineation if you're looking for pathology that pertains to the fifth cranial nerve or the trigeminal nerve. Now, identifying more deep structures, the corpus callosum has the genu and splenium. The genu is located anterior to the frontal horns, and the splenium sits posteriorly between the two atria of the lateral ventricular system. The caudate nucleus, very important structure to identify adjacent to the frontal horns. We have the thalamus that forms the lateral walls of the third ventricle. We have the lentiform nucleus that is composed of the putamen laterally and the globus pallidus medially. We have the internal capsule, the anterior limb, the genu, the posterior limb of the internal capsule, anterior, genu, posterior limb of the internal capsule. We have the external capsule, we have the extreme capsule, and the sylvian fissure. Again, very important anatomical delineation, and I'll explain to you why. These are MRI sequences, axial MRI images. Again, depicts nice depiction of the anatomy. And why is it important? Anterior limb, posterior limb, lentiform nucleus, caudate nucleus, the thalami, nicely depicted in red. Caudate, blue, the putamen, orange, globus pallidus, and purple, the thalami. This very low signal structure, these sort of low signals that you see on MRI, is iron deposition that can commonly occur, and that is situated nicely depicting the anatomy within the globus pallidus. Now, why is it important? Well, different types of pathologies affect different components of the brain. What we can see here, methanol toxicity commonly involves the putamen of the globus pallidus. So we know this is pathognomonic of methanol toxicity. Carbon monoxide poisoning commonly involves the globus pallidus. Just to reiterate, so methanol toxicity, it involves the putamen, part of the basal ganglia. Sorry, my mistake initially. And then carbon monoxide poisoning involves the globus pallidus, which is part of the basal ganglia. So very specific anatomical involvement from methanol, carbon monoxide toxicity. What I would say also manganese toxicity that commonly occurs in liver failure also involves the globus pallidus. And of course, anoxic brain injury commonly involves the basal ganglia. And the reason for that, why these components are involved in the brain, is their high metabolic activity, the high utilization of glucose, and the high mitochondrial activity that exists within the basal ganglia. Now, looking for parenchymal lesions and abscess, and what we look here is these ring enhancing lesions. We utilize contrast, and these enhance in a peripheral location usually, and these could be an abscess in the appropriate clinical context. Could also be a tumor, of course, but that's why you need the appropriate clinical information. Neoplasms. Also, we utilize contrast material, as I mentioned before, because they break the blood-brain barrier and they enhance intensely with iodinated contrast material. And a tumor usually has surrounding vasogenic edema, as would an abscess, compared to a stroke that has cytotoxic edema, not vasogenic edema. The difference, of course, cytotoxic edema involves both the gray and white matter. Vasogenic edema that's associated with tumors usually only involves the white matter. Now, when we talk about infarcts, we look for signs for acute infarction. Hyperdense MCA sign. Right here, it's a very subtle component of the hyperdense MCA sign, usually implying clot or thrombus within one of the branches of the middle cerebral artery. This low attenuating change that we're seeing peripherally within the temporal lobe and also within the parietal lobe here on your right-hand side involves both gray and white matter, and that is cytotoxic edema that is commonly seen in the presence of acute stroke imaging. I'll show more examples of stroke imaging. Looking for chronic signs of infarction, of course, we look for retractment of the parenchyma from the skull due to atrophy, so expansion of the CSF spaces. We see expansion of the cerebral sulci. We see ex vacuo dilatation effects within the brain as well, focal areas of hyperdensity, and we see mild midline shift towards the side of the atrophy. If there was an acute stroke with mass effect, the shift would be away from the lesion or away from the pathology, not towards the pathology, is what I would say. So there are signs that for us, from an imaging perspective, we can tell a clinician if we're dealing with a chronic infarct or versus an acute infarct, depending on the clinical symptomatology, but also depending on the findings that we see within the brain itself. Now, you may encounter the term microangiopathic change in reports, in radiological reports. Non-specific ischemic change is another term that you'll commonly encounter. What does this mean? This refers to age-related white matter ischemia due to microvessel disease, usually from hypertension, very commonly seen in the elderly. Its clinical significance is still unknown, but depending on the severity, it could be a clue due to underlying hypertension. Now, types of hematomas, we look for evidence for bleed. We look for subdural hematomas due to the tear of bridging veins. We look for crescentic shape along the brain surfaces, the convexity of the brains, along the interhemispheric fissures as well, along the falx cerebri is another common location, and the tutorium cerebelli. It crosses suture lines. These can be panhemispheric compared to an epidural hematoma, which is a rupture of the middle meningeal artery. This is usually associated with a temple bone fracture. Look for the biconvex lenticular shape, and these do not cross the suture lines. So examples on your right-hand side, we can see this panhemispheric crescentic high attenuation or bright structure coursing along the right cerebral hemisphere with some midline shift towards the left. This would be a subdural hematoma. Note the crescentic shape. Look at this focal epidural hematoma, again, bright, situated posteriorly to the occipital lobe. We can see the lenticular shape. It is focal, it is lenticular in its location, doesn't cross the suture line. That is definition of an epidural hematoma. These are very important distinctions to make in the acute setting because time is brain. These need to be evacuated because, you know, it's not uncommon. People will die from these types of hematomas. Now, looking for subarachnoid hemorrhage due to an aneurysm rupture, trauma, or arteriovenous malformation, blood in the subarachnoid space and or ventricles. Blood can often be seen in the interpaticular cistern initially. So, as I mentioned before, if we look at a normal brain here, which is the normal ventricular structures, we can see in the posterior aspect of the ventricle on the right, we can see this bright structure, and it's blood in the ventricular system. This bright stuff that we're seeing along the cerebral sulci, which we should be seeing CSF attenuation, is extremely bright, is blood in the cerebral sulci as well. It's a common finding of subarachnoid hemorrhage. We look at the suprasellar system right here, and this is the pons, of course, and part of the pons and midbrain that we're seeing as well. We don't see normal CSF attenuation. We're seeing a very bright structure, and the most common thing that would be subarachnoid hemorrhage. Now, intraparenchymal hemorrhage, it's important for the blood. Is it acute, subacute, or chronic? Where's it located in the brain parenchyma can be a clue to the type of pathology we're dealing with. Surrounding edema, usually cytotoxic, and usually caused by hypertension, anticoagulants, cerebral amyloid angiopathies, and also important cause of parenchymal hemorrhage as well. Cerebral amyloid angiopathy is the deposition of beta amyloid within the vessels themselves, the arteries and the arterioles, and that can cause hemorrhage. There could be microscopic, or it can be very macroscopic, that we see in this particular example. It is lobar in distribution, usually can be frontal or posterior, and there's a pathognomonic feature of a cerebral amyloid angiopathy. On your right-hand side, you're seeing an MR. This patient had dementia, and the cause could not be identified. These were microscopic hemorrhages, these dark spots that you're seeing within the right cerebral hemisphere, left cerebral hemisphere, posteriorly in the occipital lobes. These small dark spots are evidence of small foci of microhemorrhages from cerebral amyloid angiopathy that was the cause of this patient's dementia. Now, the density of the blood over time in a subdural hematoma can change. Hyperdense blood, acute less than 3 days. Subacute, it is isodense to the surrounding parenchyma. Chronic is greater than 14 days, that attains the attenuation of CSF. So those are very important distinctions that I just made, because we commonly can tell from a CT scan whether we're dealing with an acute, subacute, or a chronic hematoma. Sulci is the next important anatomical structure. We should identify the sulci within the right and left cerebral hemispheres. There should be a CSF attenuation. The Sylvian fish that we talked about form part of the boundary of the temporal lobe. Central sulcus of Rolando is a very important structure, because anterior to the central sulcus of Rolando, we have the motor cortex, and the posterior, we have the somatosensory cortex, the precentral sulcus, and the postcentral sulcus as well. Important distinctions. As I mentioned, the central sulcus of Rolando forms the posterior margin of the frontal lobe. Anything posterior to the central sulcus of Rolando is part of the parietal lobe. Sulci, remember the sulci will become deeper and more prominent as you age. Look for blood in the sulci and Sylvian fishes for indication of subarachnoid bleed that we talked about earlier on in the discussion. Now, switching to bone windows, we'll evaluate the sinuses, but also the bone windows themselves. And that's important to evaluate the sinuses. Suprasagittal sinus at the anterior interhemispheric fissure and posterior as well, very important. We have the frontal sinuses, we have the ethmoidal sinuses anteriorly that form the medial border of the orbits. We have the sphenoid sinus, more posterior to the ethmoidal sinuses, and we have the maxillary sinuses, which form part of the maxillary cavity itself. Evaluate the sinuses for any evidence of sinusitis. If you have an effluent level, that's acute maxillary sinusitis versus a normal sinus that should be normal aerated in a normal brain scan. Look for any mucosal thickening, blood in the sinuses, polyps, mucus retention cysts, or masses themselves. The bone windows, the skull itself, we have the inner aspect of the skull, the outer table of the skull. We have sutures such as the coronal and lambdoid sutures anteriorly and posteriorly. And of course, the mastoid air cells should be well aerated because if they're not, that could indicate the presence of mastoiditis in the appropriate setting, acute infection of the mastoid air cells, or if they're opacified with blood, that could indicate the presence of a temporal bone fracture, which I'll show an example. Evaluate the bone for any fractures or surgical changes, such in this particular case. This is a craniotomy performed for usually evacuation of a hemorrhage. or evacuation or surgical removal of a brain parenchymal hematoma or a tumor itself. Evaluate for subgaleal hematoma, foreign bodies. So let me go back here for a second. Subgaleal hematomas adjacent to the outer table of the skull, foreign bodies, and surgical changes that we talked about. So in recap, begin with basic identification. Remember to check for previous scans. Look at the technique. Look at each region of the brain systematically. And as we started from the middle and worked out midline structures, the ventricles, cisternal spaces, the brain parenchyma, the sulci, the sinuses, the bones, the skin, and the soft tissues. In each area, identify the major anatomy, then look for findings. Below is a list of the important things not to miss: midline shift, ventricles for blood and mass effect, cisterns for blood and pus, the parenchyma, signs of ischemia and or bleeding, sulci for blood, sinuses for sinusitis or masses, bones for fractures, and soft tissues for hematomas or foreign body. So let's go through some must-see cases. So case 1, 65-year-old female with a history of hypertension, diabetes, coronary artery disease, presents with emotional liability, loss of orientation, apraxia, which has affected her activities of daily living, now presents with acute onset of right arm, right leg deficits. In the differential, most likely that the number one thing you want to exclude, of course, is an acute ischemic insult. Number one test of choice we talked about is a CT of the brain. So let's look at this example. If we look at the anatomical delineation where the supraclinoid portion of the ICA sits, you have a right and left. The beauty of the brain, we have a right side and a left side, and we should also always look. We've also got the clinical history. So if we're looking at the supraclinoid portion of the ICA, we see a very bright spot. We look at the middle cerebral artery, we see a bright spot as well. We're seeing also a bright spot along the interhemispheric fissure as well. Now, what we are seeing as well is loss of the normal anatomy that I described. It can be subtle. This takes time and practice to be able to identify these findings that I just talked about, but this bright structure implies an acute thrombus or clot. The next step, what we looked at right here, is the normal anatomic delineation of the caudate, lentiform nucleus that I talked about before, the antria, posterior of the internal capsule, compared to the left side where that is lost due to the presence of cytotoxic edema. Now, this was initially missed. If this finding is missed, of course, on follow-up imaging, which we'll see, this is what transpires with a stroke. You have extensive cytotoxic edema that involves the gray and white matter. You have effacement, mass effect that I talked about of the frontal horns. You have displacement of the interhemispheric fissure towards the right of the midline, and you're starting to get subfalcine herniation as well of the cingulate gyrus. And this is the clot in the anterocerebral artery. So very important distinction to identify the normal anatomy to make this diagnosis in the acute setting. Compared to the right side, where we can see nicely the lentiform and the caudate nucleus, the antria and posterior limb of the internal capsule. Again, thrombus within the left supraclinoid portion, the MCA, loss of that anatomical delineation that I will once review, midline central, right and left frontal horn, anterior limb, posterior limb of the internal capsule, caudate, lentiform nucleus, thalami, external capsule, extreme capsule, sylvian fissure. That anatomy is lost when you have a stroke. So diagnosis acute left ACA, MCA infarct. What about this particular example? We have a left side, right side of the brain. Left side, nothing remarkable. Right side, we see a very bright structure in the supraclinoid portion of the ICA and also in the M1 segment of the medial cerebral artery. We're seeing low attenuating change. We're seeing effacement of the right temporal horn compared to the left side. So we have edema. We go more superiorly. We can see how extensive this edema is. Again, I draw your attention to the normal anatomy. Anterior limb of the internal capsule, posterior limb of the internal capsule, external capsule, extreme capsule, sylvian fissure. This anatomy is completely lost. On the right-hand side implies an acute stroke. More superiorly, midline shift towards the right due to the cytotoxic edema and the mass effect that occurs with stroke in evolution if we don't treat these strokes in the appropriate time frame. Let's look at the next case, acute onset of left side weakness and numbness. Again, initial imaging modality would be, of course, a CT of the brain. What are we seeing? We're seeing clot within the M1, so the M1 and M2 branches of the MCA, because it's bright. As I said before, if it's bright, it implies it could be an acute thrombus in the appropriate clinical context. What does this imply? It implies thrombus or an embolus, and that implies a sign of acute stroke. We must act definitively. And I'll show another example, acute onset of right side weakness. What will be the initial imaging modality in this particular case? Let me just go back for a second. So this is the patient will present with left-sided symptoms with acute thrombus in the MCA. In this particular example, the patient has right-sided weakness, so we're looking at the left side. For the pathology, we see again a very bright structure in the middle cerebral artery. Again, this implies thrombus, a very important anatomical distinction to make in the acute setting in the appropriate time frame. The reason why I emphasize this is because time is brain. Time is brain. Again, loss of the normal anatomical delineation, obscuration of the lentiform nucleus on the left, where we can see the lentiform nucleus on the right. Now, your next step in management that we commonly do in stroke imaging is to perform a CT angiogram. We give iodinated contrast material that opacifies the vascular structures, of course. And what do we see? So we have a right side and a left side. We know the pathology on the left side based on the non-contrast CT examination. We had that bright spot that was the thrombus. Now we look at the site where we saw the bright spot and we're seeing a filling defect. What do I mean by filling defect? It means that we don't see a tubular structure that is filled. The whole vessel is not filled with iodinated contrast material as we see on the right-hand side. We see another beautiful depiction of the M1 segment of the middle cerebral artery. We see a nice tubular structure filled with bright contrast material. It is not filled in more proximal in the M1 segment. That is a clot. This is a great illustration of a proximal occlusion of the middle cerebral artery that is very amenable to endovascular treatment, where we place catheters and suck out the clot and save the brain. So very important distinctions to make in the appropriate time frame, in the appropriate clinical setting. Must see cases, must act immediately to save the patient. Next case, a 45-year-old patient presents with head trauma and a GCS of 8. Initial imaging modality would be a brain CT. What are we seeing in this particular example? Some very dramatic findings. What we're seeing is midline shift to the right. We're seeing a crescentic hematoma, subdural hematoma. We're seeing parenchymal hemorrhage. We're seeing displacement of the midbrain. We're seeing Duray's hemorrhages due to the tearing of the bridging basilar perforators that stretch and tear and cause these Duray hemorrhages in the brainstem. We're seeing blood within the uncus, the most medial portion of the temporal lobe that is herniating over the tentorium. And we see parenchymal, crescentic, panhemispheric hemorrhage, midline shift towards the right, subdural hematoma. Next step, surgical evacuation. Must see case, must act immediately. You stop the scan and you get the patient off, you send them up to the OR. Next case, again, more subtle, crescentic blood along the left hemispheric, left aspect of the brain parenchyma. It is panhemispheric, coursing along the occipital lobe, temporal parietal lobe, frontal lobe, midline shift to the right, subdural hematoma, must be evacuated. Next case, motor vehicle collision, Glasgow Coma scale of 6. Initial imaging modality, of course, is a CT of the brain. What are we seeing here? We're seeing a very focal area of collection in the extracranial space, extraaxial space. This is more convex. This is more, it is not panhemispheric. It is not crescentic. This more implies that this is an epidural hematoma. We have a subgaleal hematoma as well. We have some displacement of the outer inner cortex of the bone. We have some very low density material within the epidural hematoma as well. So what is that? Let's change the bone window that I talked about at the beginning of the talk. So now this is a bone window. We see the bone structures very nicely. We see a depressed skull fracture. We see areas of very low attenuation, which is air. You can put a region of interest to verify that. If it's negative 1,000 Hounsfield units, so that is air, that implies pneumocephalus and also depressed skull fracture and epidural hematoma that also needs to be evacuated. Next case, patient had traumatic fall. What would be the initial imaging modality? Of course, it is a CT of the brain. What are we seeing here? What we're seeing here is subfalcine herniation of the cingulate gyrus, displacement of the body of the left lateral ventricular system, midline shift to the right. We're seeing an epidural collection that is located along the temporoparietal region. The reason why I put here epidural or subdural, because sometimes it can be very difficult to tell whether you're dealing with an epidural or subdural. It doesn't matter, is what I would say. If you're having that diagnostic difficulty, just call it a hemorrhage that is located in the extra-axial space. We know that because it is causing significant mass effect and displacement of the gray and white matter away from the actual hematoma. Also, it is causing midline shift, displacement of the left lateral body of the ventricular system, mass effect. That is the most important that I want to drive home. There is mass effect associated with this hematoma. This needs to go to the OR to be evacuated. That is what you need to identify in the acute setting. A must-see case, must not miss finding. So, epidural versus subdural. Epidural, localized, convex, or lens-shaped, and do not cross suture lines. Subdural hematomas, convex, crescentic-shaped, or panhemispheric, and may cross the suture lines. So, epidural hematomas, subdural hematomas. Sometimes you can make the distinction. Usually epidural, rupture of the middle meningeal artery, subdurals due to rupture and tearing of the bridging veins. Patient had a fall, current GCS of 8. What would be the initial imaging modality? Of course, CT scan of the brain. What are we seeing here? I talked about before, identifying normal anatomy is the key to identifying pathology. And that's one of the things that I've emphasized throughout my 3 lectures. What are we seeing here? What we should be seeing is CSF attenuation of the basal cisterns. What we're seeing instead in the suprasellar cisterns is areas of high attenuation. The prepontine cistern, the ambient cistern, are displaying high attenuation. And this is pathognomonic of subarachnoid hemorrhage. So along the interhemispheric fissure, we're seeing bright attenuation, along the sylvian fissures as well. That is, these are common sites of subarachnoid hemorrhage. Now, what is the cause? Most common cause of subarachnoid hemorrhage is trauma, but in this particular case that it's localized to the cisterns, usually a ruptured barianeurysm, common locations, intracommunicating, middle cerebral artery, supraclinoid, basilar tip aneurysms, very common locations for aneurysms. Acute onset of headache with signs of meningismus. Again, what are we seeing here? Let's look at an example. So I'm showing on the right-hand side a normal CT of the brain, and what I'm showing on the left is a CT of the brain that is abnormal. Instead of seeing CSF attenuation, we're seeing areas of high attenuation within the brain cisternal spaces. Depiction, it should be of low attenuation. It is high attenuation, indicating the presence of blood. What are we seeing here as well? What we're seeing is blood along the interhemispheric fissure, along the sylvian fissures, and we're seeing blood usually layering posteriorly in the atria or the occipital horns of the lateral ventricular system. What is the next step in management? A CT angiogram. And in this particular example, we're seeing a bulging and outpouching of contrast material, which is an aneurysm at the level of the anterior communicating artery, that it bridges the 2 A1 segments of the anterior cerebral artery, common location of an aneurysm. That is also depicted on the angiogram, and usually the treatment of choice is coiling endovascular treatment of these aneurysms. Now, next case, patient had a history of hypertension and presents with confusion. Initial imaging modality in the acute setting is a CT of the brain. We're going from the bottom to the top of the skull, and we can see big, massive hemorrhage in the left aspect of the cerebellum with displacement of the 4th ventricle. This is an important finding because these types of hematomas can decompress and cause further herniation of the cerebellar tonsils down into the foramen magnum, where your medulla exists, which is your respiratory center, and also the upper aspect of the cervical cord, and can cause respiratory depression and sudden demise of the patient. So they need to be evacuated. Next case, headache, worsening of the past few days post-vaccination. Query VIT, which is the vaccination immune-mediated thrombocytopenic thrombotic occlusion. So this VIT syndrome is a common thing we see now with the pandemic and so many vaccinations that are occurring. The initial method of investigation, the non-contrast of the brain. And usually on this non-contrast, we talked about the anterior and posterior aspects of the interhemispheric fissure and the supraesophageal sinus. Now, if it is extremely bright on a non-contrast CT scan, I'm saying, that could imply a thrombus. Now, how do you evaluate this? Well, the next best test is to do a CT venogram, is what we commonly do. So in this example on your left-hand side is very dense transverse sinuses, and that implies that could be thrombus. And we can see on the CT venogram, there is no opacification of the transverse sinus, what we call a filling defect, meaning clot within the transverse sinuses. Another example is called the empty delta sign. We can see the supraesophageal sinus should be completely homogeneous, opacified with contrast material. We're seeing a filling defect, a low density in the center of the supraesophageal sinus, called the empty delta sign, and that implies a clot within the supraesophageal sinus posteriorly. Another example of VIT, thrombotic occlusion that is induced post-vaccination. We have a hemorrhage in the left temporoparietal lobe of the brain that's induced from this venous occlusion of the transverse sinus, part of the sigmoid and petrous sinus as well. That you have occlusion that's causing this hemorrhage as well. So dural venous thrombosis, very important, could require heparin. Sometimes there could be some endovascular treatments as well, but it needs to be identified in the acute setting with a non-contrast CT of the brain, and then, of course, a CT venogram. Next case, blunt, and we're finishing with the last few cases here. Blunt head injury, what would be the initial imaging modality? CT of the brain, these are bone windows. Let's magnify this slightly. We can see this is the mastoid air cells. These are the ossicles. We can see these are opacified with blood, and we can see a very fine linear line that's disrupting the mastoid cavity or the temple bone. And we can see this is a linear fracture of the temple bone. Complication, of course, would be a conductive sensory hearing loss, which can be a complication of temple bone fractures. This is the last two cases that I'm going to finish with. This was a self-inflicted nail gun injury. This was a chest X-ray, which was very difficult to see the nail that was introduced by the patient. We see a skull X-ray. We see these linear densities along the left and right and left aspects of the skull. We'll do a CT angiogram, and we'll do a volume rendered image. And I've talked about this before in my talks, how important these are. These are very important from a surgical perspective to identify the anatomical location of these nails and other compromising any significant vascular structures before they are removed. And what we can see as we rotate this image, we can see these vessels are well opacified with contrast material, and they're not impeding or crossing or disrupting the critical vascular structures that are opacified with contrast material. And of course, unfortunately, this patient also self-inflicted these into the chest. And we can see one here anteriorly, posteriorly, the right and left aspect of the chest. We can see a nail entering the right ventricle, left ventricle, and we can see blood in the hemopericardium, blood in the pericardial space. The patient was transferred to the OR immediately, and this patient was saved and is doing much better. So I'm going to bring this all together. So this was an SUV versus a logging truck. Unfortunately, the logging truck won in this particular case. So we start from the top. And this brings the whole 3 talks together that I've talked about. We have crescentic panhemispheric hematoma, the right side of the cerebral hemisphere. So we have a subdural hematoma. We have intraventricular hemorrhage in the 4th ventricle. We have sagittal view of the C-spine, anterior, posterior, with the foramen magnum. We have a dislocation. This is the C2, C3, C4, C5, C6 at the level of C6, C7. There's a translocation of the C6, C7. We will need an MRI, of course, to ascertain the damage to the spinal cord. We did a CT angiogram, and what we're seeing here in the foramen transversarium, the right vertebral artery, non-opacification of the left vertebral artery, a filling defect, implying complete occlusion of the left vertebral artery. We're seeing the chest, lung windows. We're seeing a pneumothorax, accumulation of air within the pleural cavity. What we're seeing in our soft tissue windows of the abdomen, we're seeing disruption of the spleen, devascularization of the spleen. We can see this low density, so a splenic laceration and devascularization of the spleen. We're also seeing traumatic disruption of the right hemidiaphragm as well. And then further inferiorly, bone windows, there's an acetabular fracture, soft tissue windows, active contrast extravasation due from the pelvic fracture, that the patient was transferred to the interventional radiological unit where this bleeding was stopped and the patient's life was saved as well. So bring it all together using different window and levels, knowing our anatomy, the different anatomical compartments, and identifying these types of acute injuries that we must identify in the acute setting in order to decrease the mobility and mortality of these patients. Thank you for your attention, and that concludes the session.
Excellent. Thank you so much, Dr. Nicolaou. So we're opening up for questions here. So please engage in the Q&A if you have any questions, and we'll start off with some of the questions we've already collected here. So Dr. Nicolaou, thank you so much for those great cases, the breakdown of the anatomy, what you identified, pathology. I had a question here about subfalcine herniations and how they vary in type and etiology. So are there approaches to dealing with subfalcine herniations, or are there herniations that avoids invasiveness of surgery, and how can we determine that?
Yeah, it's an excellent question. I think, I mean, there are different types. You have, the transtentorial herniations can be supra or infradentorial, of course. The infradentorial was the example that I showed, the cerebellum with the hemorrhage in the left cerebral hemisphere that causes an infratentorial, transtentorial herniation through the foramen magnum, and those can be devastating and have to be treated immediately because, as I talked about, those cause compromise of your respiratory center, which is located, in the medulla, and your brainstem that causes compromise. So those can have severe, drastic consequences. The other types of herniations, the self-falcine that we talked about, the singular gyrus crossing across the midline, those can be severe as well, depending how severe the herniation is, as they can cause compromise of the vascular structures, such as the anterocerebral arteries that can cause compromise and ischemia to the brain. It all depends how severe they are. The next important herniation, I talked about the one in the cerebellum, is of course the mass effect that occurs within the medial aspect of the temporal lobe, which is the uncus, what we call uncal herniation, that herniates over the notorium cerebelli and causes, of course, mass effect within the brainstem itself. And those can be very significant as well. And I think it's just to have experience in knowing, I mean, herniations can be caused from anything. It could be a hematoma that I showed in the cerebellum. It could be from hypertension itself, anticoagulants. It could be trauma that I showed, the temporal lobe hematoma that was causing the uncal herniation, or it could be a tumor that might be causing self-falcine herniation, along the singular gyrus that could cause it as well. So it all depends how rapid, how quickly and expanding the herniations occur, that and you have to base it, of course, in the clinical context and, of course, the GCS status of the patient.
Great, thank you for that detailed answer. Jamal here has a question. Says, thank you very much, and is wondering if subdural and epidural hematomas can occur together, and if so, what are the approaches to identifying this occurrence?
Yeah, they can occur together. The approach again is what I would say: look at the whole extent of the brain, and subdural hematoma would be panhemispheric. And what I mean by that is it would course along the frontal lobe, temporal lobe, parietal, occipital lobes, and that's what I call a panhemispheric, and can be crescentic. You can have a crescent, and I've seen these. As I showed in one example, is a crescentic hematoma that courses along the whole hemisphere, but then you can have a focal lentiform shaped hematoma that is more focal, more localized to a particular component of the extraaxial space, whether it be the temporal lobe or it is the along the posterior aspect of the brain. And some of the key differentiating features is the localized component, that it could be more expansile, more larger at that particular area, but also look for a fracture. If you see a fracture of the occipital bone, you see a fracture of the temporal bone, then you know that most likely you're going to have an epidural component on top of a superseding subdural component as well. And that's the best way to differentiate. Sometimes you might not be able to, but usually if you see a crescentic panhemispheric hematoma, it's subdural. If you see it more localized, more expansile in a particular anatomical location with an associated fracture, most commonly you'll have an epidural hematoma associated with that fracture.
Great. All right, thank you for that answer. I've got a question here from Simon, and is wondering, is it possible to have brain atrophy in all cases of alcoholism? And
Of alcoholism?
Yeah, alcoholism, yeah.
Yeah. It depends, I mean, when we say alcoholism, I assume the question is implying chronic utilization of ethanol or alcohol over a period of time. It can. There are features where alcohol can cause certain aspects of the brain to atrophy, such as the cerebellum. Is a common location where we see alcohol cause cerebellar atrophy. Can be a clue to the utilization of chronic usage for alcohol. But yes, it can. But what I would say to everyone, we all have different genetic predispositions, is what I would say. And it depends how much alcohol you're consuming per day, over what period of time. And of course, depending on your genetic predisposition, some people might see more significant changes than other folks. But usually alcohol over a chronic utilization period, depending on how many drinks per day, you'll definitely see signs of atrophy.
Excellent. And we can maybe finish up with this last question. And it's going back to when you mentioned the CT angiography, and just wondering, what are the criteria? Like, when would you know that the most reasonable next step would be to perform a CT angiography?
Yeah, the CT angiogram, I mean, it's a very commonly performed examination. When is it performed, the CT angiogram? Any stroke, it is always performed. It goes with bread and butter. Butter being your CT angiogram, bread being the non-contrast CT for stroke. Anytime you have a stroke case, you will always get a CT angiogram. Another common indication is vertigo. Another common indication is chorionic dissection, a tearing of a vessel. Workup of subarachnoid hemorrhage. Workup of sometimes parenchymal hemorrhages, wanting to identify the cause of that parenchymal hemorrhage. Is it from a vessel? Is it subarachnoid hemorrhage? Is there an underlying vascular malformation that might be causing that hemorrhage? So workup of hemorrhages, workup whether it be parenchymal, subarachnoid, stroke imaging requires CT angiography. Even tumors might require CT angiograms with a post-CT angiogram contrast of the brain as well. assessing for the presence of tumors, but vascular malformations, the workup of subarachnoid hemorrhages, the workup of an aneurysm, the workup of stroke, the workup of vertigo, the workup of a dissection, all require CT angiograms, is what I would say. Of course, if you're looking at clot within the venous anatomy that I talked about with the mass vaccination effort that is underway with the pandemic, then of course you would have to time your contrast bolus to the venous side of the anatomy to look at venous occlusions, as I showed, whether it be the sagittal sinus, the transverse sigmoidal sinuses, or some of the deep venous anatomy that can occur with post-vaccine deployment.